Managing immunosuppression after a liver transplant, it's a real high-stakes balancing act. Today, we're going to build a super practical framework to help you cut through the complexity, absolutely nail your boards, and make those critical calls with a ton of confidence. So let's start with a situation that you will definitely see.
All right, let's jump right in with a classic scenario. Imagine your own call overnight. You've got a patient 3 months out from their transplant who's been doing just fine. But 5 days ago, they started fluconazole for some oral thrush. And now? Their labs are a mess, LFTs are up, creatinine is up, and they've got this new hand tremor. So here's the million-dollar question we're going to solve together. Are we looking at rejection, drug toxicity, maybe an infection, or is it some awful mix of all three?
Okay, before we even start talking about specific drugs, we have to get our heads around the fundamental philosophy here. Managing these patients is not about nuking the immune system into oblivion. Nope. It's all about finding that perfect, delicate sweet spot, that balance between preventing rejection on one side and avoiding the really bad stuff on the other. Infection, cancer, and the drugs poisoning the patient. This is a constant, dynamic tightrope walk.
So how do we even begin to tackle that differential? Well, the first and most important clue is always time. We break down post-transplant care into 3 distinct phases. First, there's induction, those first 3 months where it's all hands on deck to prevent acute rejection. That means intense therapy. Then, way down the road, after a year, you're in the minimization phase, trying to dial back the drugs to avoid long-term toxicity. And our patient? At 3 months, they are smack dab in the middle of the maintenance phase. This is where they're on that calcineurin inhibitor backbone. We're trying to stabilize things, but it's also exactly when all the classic drug side effects and metabolic problems love to rear their ugly heads.
And listen up, because this is a huge pearl for your boards and for the wards. This 3 to 12-month maintenance window, this is where the action is. It's where so many of the classic complications pop up, making it an incredibly high-yield zone for any exam question and, frankly, for most real-world problems. The dust has settled from the surgery, and now we get to see the true effects of the drug regimen.
To get a handle on all these drugs without your head spinning, let's just sort them into 4 simple buckets. First up, the absolute backbone of pretty much every regimen, the calcineurin inhibitors, or CNIs. Tacrolimus is the modern workhorse here. Then you've got your adjuncts, like mycophenolate or MMF, that help us use less of the CNI. Next are the alternatives, like mTOR inhibitors, which are super important for special cases, like trying to save the kidneys. And of course, good old steroids, the foundation of pretty much all early therapy.
Okay, here's the absolute key to not getting buried by all of this pharmacology. It's all about pattern recognition. Seriously, if you can just burn these classic toxicity patterns into your brain, you can solve almost any clinical problem they throw at you. This isn't just trivia. It's a powerful diagnostic weapon. I mean, knowing that mTOR inhibitors mess with wound healing, that's pretty critical before you decide to take a patient back to the operating room, right?
So, let's make this stick. For our workhorse drug, tacrolimus, I want you to remember TAC. Simple. T is for tremor, A is for AKI, or acute kidney injury, and C is for carbs, because this drug loves to mess with blood sugar and can even cause new-onset diabetes. Now, think back to our patient in the case. What did they have? A tremor and a rising creatinine. See? 2 out of 3. The pattern is already shouting at us.
So how does tacrolimus stack up against the older drug cyclosporine? Well, the main difference is really in their signature toxicities. Like we said, for tacrolimus, you think brain and sugar. For cyclosporine, you got to think cosmetic side effects. I've got a great mnemonic for this one. Cyclops. Yeah, seriously. Think of a cyclops with big gums from gingival hyperplasia and big hair from hirsutism. It sounds ridiculous, I know, but trust me, you will never forget it. All right, quick pop quiz. Let's see if you were listening. You have a young patient, and they are really upset because their gums are getting puffy and they're growing new hair on their face. What's the drug? Come on, 5 seconds, you got it. That is the textbook picture of cyclosporine. See? It works.
Okay, let's talk about one of the biggest, most common traps in all of transplant medicine. Why do the levels of these CNI drugs, especially tacrolimus, seem to bounce around all over the place? The answer is all about how the body gets rid of the drug, and you have to get this right. So here's the deal. Tacrolimus gets broken down by this enzyme in your gut and liver called CYP3A4. Now, some drugs are inhibitors. They block that enzyme, they gum up the works. So what happens? The tacrolimus can't get broken down, and the levels shoot way up, leading to toxicity. And what's a classic inhibitor? You guessed it, azole antifungals, just like the fluconazole our patient is on. On the flip side, you have inducers. These drugs rev up the enzyme, making it work overtime. It chews through the tacrolimus way too fast, the levels plummet down, and now you're at risk for rejection.
Okay, let's flip that coin. Here's another classic board scenario for you. A patient gets treated for TB with rifampin, which is a monster CYP3A4 inducer. A few weeks go by, and their LFTs start to climb. What's going on here? Well, the rifampin has been revving up that enzyme, it's been gobbling up all the tacrolimus, the drug levels are now in the basement, and the patient is probably having acute rejection.
So all of this leads us to a super important safety checklist. When you see those LFTs start to creep up, you can't just jump to rejection. That is a diagnosis of exclusion. You have to be systematic. First, rule out infection. Then, review that med list like a hawk for any new interactions. Third, check the drug level. And fourth, this is huge, get a Doppler ultrasound to make sure there isn't a vascular or biliary plumbing problem. Only after you've done all that and things are still unclear do you even start thinking about a liver biopsy.
And this right here, this is probably the single biggest mistake you can make. The most dangerous knee-jerk reaction is to just blast a patient with steroids because their LFT's bumped. Think about it. What if the real problem is a brewing infection? Or worse, a clot in their hepatic artery? Giving them a huge dose of steroids in that situation could be an absolute disaster. And this isn't just about the short term. It's why we aim for minimization long term, to reduce the total burden of these drugs and lower the risk of all the bad stuff like cancer and kidney failure down the line.
So, when is it a no-brainer, absolutely mandatory, that you check a tacrolimus level? Well, I've got 5 triggers for you. Any new kidney problem or new brain symptom, anytime you start or stop one of those interacting CYP3A4 drugs, any major change in their liver function tests, and then there's the really weird one, the one that trips everyone up, diarrhea. You'd think it would make you absorb less drug, right? Wrong. It actually damages the gut lining where that enzyme lives, so you end up absorbing more of the drug and the levels can go through the roof. That is a critical board favorite pearl.
All right, team. We've gathered all the clues. Let's go back to that patient from the beginning and solve this case like the safe, smart surgeons we are. So let's recenter ourselves on their context. They're in that maintenance phase, right? They're probably on a standard combo of tacrolimus and MMF. This isn't the all-out assault of the induction phase, and it's not the fine-tuning of the minimization phase. Just understanding where they are in their timeline is half the battle.
So let's run our checklist step by step. 1. Review the med list. And bingo. There it is in plain sight. They started fluconazole, a classic, potent CYP3A4 inhibitor. 2. Look at the clinical picture. The tremor, the AKI, that's our TAC mnemonic screaming at us. These are classic signs of tacrolimus toxicity. So step 3, we check the level, and you can bet your career it's going to be sky high. And that leads to our conclusion. This is not rejection. This is drug toxicity that we caused. So what's the next best step? You hold the tacrolimus, you recheck the level, and you absolutely do not give them steroids.
All right, screenshot this one, folks. This is your night before the big exam all-in-one cheat sheet. Remember, the goal is always balance. Know your phases: induction, maintenance, minimization. Know your toxicity mnemonics. TAC is tremor, AKI, carbs. Cyclosporin is gums and hair. MMF is GI and marrow. And mTOR is torn wounds and lipids. Don't forget, diarrhea makes tacrolimus levels go up. Inhibitors like azoles make levels go up, causing toxicity. Inducers like rifampin make levels go down, risking rejection. And for any LFT bump, check a level and get a Doppler first, biopsy last.
So, what's the big takeaway here? It's that managing immunosuppression isn't some dark art. It's a game of rules, patterns, and checklists. And if you know the rules, you can avoid the most dangerous traps. We've really hammered home how drug toxicity can mimic rejection, but it's not the only thing. The key question you should always be asking yourself is, what else could this be? It's about seeing that entire big picture, from the initial drugs they get to the long-term risks of cancer and kidney disease. And keeping that differential diagnosis broad, well, that's not just a skill for passing tests, it's what keeps your patients safe.